All right, chapter 25 is the second chapter in this module, and hopefully this will be two short little lectures talking about blood supply and fluid dynamics and sort of the disorders associated with that would be stroke and intracranial pressure, cerebral edema. So we'll sort of divide it into those two sections. And just talk briefly about it. So in the book there is a lot of detail on the cerebral arteries, and we're just going to really hit the high points on them. So for the learning objectives, I want you to learn what a transient ischemic attack or a TIA is, and how does it differ from a CVA or cerebrovascular accident. So we're going to talk about each of those. I want you to be able to identify characteristic stroke signs by arterial location. So we're going to talk about some of the major arteries and the characteristic stroke signs that identify a stroke involving that individual artery. So I want you to pay particular attention to those distinguishing signs. So there might be signs and symptoms that are common between all the arteries. Several of them you could end up with hemiplegia or hemisensory loss. A lot of them you can end up with some similar symptoms, but there's a characteristic distinguishing sign that identifies each individual artery. And hopefully to help you, I have them in bold in the PowerPoint. And I want you to be able to, like, you hear a certain sign and you say, well, that's the middle cerebral artery, or that's the posterior cerebral artery. So we're going to talk about that. So the loss of blood supply in a specific area of the brain will correlate with a specific loss of function. That makes sense from what we've talked about so far in the brain. In the next module, we're going to talk about the cerebrum and more about specific functional areas of the cerebrum. But usually episodes of vascular supply problems are classified according to both the pattern of progression and the cause of the disorder. So a transient ischemic attack, when you think of that, transient means it comes and goes. Ischemic is we have a blockage in its attack. So it's a brief focal loss of brain function, and this is the key part, with a full recovery from neurological deficits within 24 hours. So a lot of times you can sort of think of, when we were talking about cardiovascular disorders and pathology, we said angina was a temporary blockage, temporary ischemia in the heart, and then a myocardial infarction was a full blockage where you actually had damage to the myocardium. So a transient ischemic attack is sort of like the angina of the brain. So it's a brief focal loss. A lot of times when you are working in acute care, you will see people admitted to the hospital under the diagnosis of TIA versus CVA. So what they're going to do is they're going to observe that person for 24 hours, and you're going to say, are they really having a stroke, or are all of the symptoms going to go away within 24 hours and it's the TIA. But just like with angina and myocardial infarction, ongoing episodes of angina can then develop into a full-blown myocardial infarction, and continuing episodes of TIAs can develop into a full CVA or stroke. So if someone's having several TIAs, that could be the indicator that they're eventually going to have a stroke, sometime soon. Okay? But that's really the main difference, is you have a full recovery from neurological deficits within 24 hours. So a CVA, or cerebrovascular accident, is what we call a stroke. So some members of the medical community are advocating the terminology brain attack as a layman's term to replace stroke, to emphasize that prompt treatment may benefit some people who have had strokes, just as prompt treatment is effective for some people who have heart attacks. So it used to be like back in the early 80s when I worked in the emergency room and on the ambulance, if somebody came in with a stroke, there wasn't all that much we could do for them. We could monitor their vitals and make sure they, just watch and see how they were doing. Now they have the clot busting drugs if it's an ischemic stroke. An infarction, they can do microsurgery to remove clots. There's a lot that can be done potentially for someone to limit the effects of a stroke. So as soon as you notice something going on with someone, that's when you got to get them right into the emergency room. So we classify the different kinds of strokes as to whether or not they are progressing. So a completed stroke is where neurological deficits from vascular disorders persist more than a day, and they are stable. In other words, they're not getting worse. A progressive stroke is deficits that are getting worse. They increase intermittently over time. So it might be an intracranial bleed. It might be something else that is causing the stroke that causes it to progress. So usually an ischemic stroke is often a completed stroke. It's not getting any worse. If the neurological vascular disorders don't persist more than a day, then it's considered a transient ischemic attack. So a brain infarction, which is another name for an ischemic stroke, occurs when an embolus or thrombus lodges in a vessel obstructing blood flow, just like with a myocardial infarction, but this is in the brain. So typically, an embolus abruptly deprives an area of blood, resulting in an almost immediate onset of deficits. So a lot of times people will report, all of a sudden my speech was slurred, all of a sudden the one side of my face was drooping, all of a sudden I couldn't raise one arm. So it's that sudden onset. Obstructions of blood flow in small, deep arteries result in what are called lacunar infarcts. And this picture from the book is that lacunar infarct, almost like little pits. A slow occlusion of an artery has a different outcome from an abrupt occlusion. Okay, so slow occlusion, you're going to get the small incremental progression over time, and abrupt occlusion is bam, the symptoms come on. A hemorrhagic stroke is where you have either an arteriovenous malformation burst or an aneurysm burst. Downstream vessels are deprived of blood, and extravascular blood exerts pressure on the surrounding brain. So intracranial hemorrhage is usually more devastating to a person than a brain infarction, just because there's more potential for tissue damage. Certainly brain infarctions can affect large areas too, but hemorrhages usually affect large areas quicker. So it usually results in the worst deficits within hours of onset, but then improvement occurs as the edema decreases and the extravascular blood is removed. So depending on how long that happens, so one of the things when you get someone in quickly with an ischemic stroke, a brain infarction, they can try to use the clot busting drugs, they can try to surgically remove clots. With hemorrhage, they can try to do surgery to decrease the hemorrhage. So there are things that can be done on an emergent basis to try to minimize the damage. However, there's still going to be damage, resulting in symptoms. So a subarachnoid hemorrhage, that's where the hemorrhage is in between the arachnoid and the pia mater, which is adhered to the brain. And it causes sudden excruciating headache with a brief loss of consciousness, maybe for a few minutes. Initially, the findings are not focal, meaning that there's blood in a lot of different areas. The deficits are usually progressive because of continued bleeding or secondary hydrocephalus. Vasospasm and infarction are common sequelae, which means it happens after a subarachnoid hemorrhage. So this is a really serious progressive stroke that can cause serious other problems later on. So when strokes can involve a main artery, a smaller branch of arteries, capillaries, or arteriovenous formations where the arteries are changing into veins, basically. So depending on which artery or branches are affected, you'll get different symptoms because it'll affect different areas of the brain. So the vertebral and basilar arteries, they supply the posterior, inferior part of the brain, so like the cerebellum and cranial nerves in the brainstem. 20% of ischemic strokes affect the brainstem and cerebellar regions. So a large percentage affect the cerebrum, but 20% is So the symptoms that we talked about in previous modules about brainstem and cerebellar symptoms, those are going to be the symptoms you're going to see in this type of stroke. So one of the chief symptoms of the vertebral artery is pain in the posterior neck or occiput, spreading to the shoulders. Remember how we talked about ataxia being one of the main symptoms of cerebellar dysfunction? So one of the most common signs of vertebrovascular artery ischemia is gait and limb ataxia. Limb weakness, oculomotor palsies because it affects the cranial nerves, and oropharyngeal dysfunction also affecting the cranial nerves. So dizziness and vertigo are common symptoms in acute cerebellar infarction, or inability to sit upright, difficulty walking, nausea and vomiting, dysarthria, and headache. Complete occlusion of the basilar artery can cause death as a result of ischemia of brainstem nuclei and tracts that control vital functions. So the main thing I want you to think about is cerebellar symptoms and cranial nerve symptoms. So we're talking about ataxia and either eye movement or swallowing dysfunction. So those are kind of the hallmark symptoms of these two arteries. Of all of the ischemic stroke incidents in cerebral arteries, by far the majority of them are in the middle cerebral artery. So this graph is from the book, and it is the pie chart. And that big red area, 69% of ischemic strokes happen in the middle cerebral artery. So the symptoms that we sort of think of as classic stroke symptoms, those are MCA stroke symptoms. Okay, so we'll talk about them. And then all the others are smaller percentages. So we just talked about the vascular, 7%. Posterior cerebral, 2%. So really small percentages on those, but a whopping 69% on those MCA strokes. So the anterior cerebral artery affects the anterior part of the brain. So strokes affecting the anterior cerebral artery are going to result in personality changes. Also with contralateral hemiplegia and hemisensory loss, but that's a common symptom with other cerebral artery strokes. But the personality changes, that is the hallmark sign of an anterior cerebral artery stroke. The other ones you go, okay, it might be something else, but those personality changes, you know that the frontal lobe is involved, and you say, okay, that's the anterior cerebral artery. So, of course, they can always cause motor dysfunction because it affects other areas in the motor thalamus and some of the other areas, but those personality changes, that is the main symptom I want you to think of for an anterior cerebral artery stroke. For middle cerebral artery, these are what we sort of think of as sort of the classic stroke symptoms because 69% of ischemic strokes are middle cerebral artery. So it often gets the sensory motor cortex and the adjacent white matter. So homonymous heminopia, that's the where you lose one side of each eye. Combined with contralateral hemiplegia and hemisensory loss involving the upper limb and face. Very common symptoms. You can also get contralateral hemiplegia that affect the upper and lower extremities and face, as well as aphasia. And aphasia is difficulty with speech. In the next module, we're going to talk about specific types of aphasia and what areas are affected with those. The areas on the opposite side of the brain involve spatial relationships, and neglect and impairment of nonverbal communication often occur with middle cerebral artery strokes as well. So it depends on which side is affected. If the left side of the brain is affected, you're going to get the aphasia. If the right side of the brain is affected, you're going to get the neglect and impairment of nonverbal communication. So homonymous hemianopia, the aphasia, and potentially neglect. So those are our middle cerebral artery hallmark signs. Posterior cerebral artery, the posterior part, we might get eye movement paralysis because it affects the oculomotor nerve, but sort of the hallmark symptom when it affects the occipital lobe is cortical blindness, because we're messing with the cerebral cortex area that processes visual information. So a stroke affecting one side of the occipital lobe is going to result in loss in the contralateral visual field, so cortical blindness. Lack of blood flow to the thalamus can also cause what's called thalamic syndrome, severe pain, contralateral hemisensory loss, and flaccid hemiparesis. That is certainly less common than some of the other symptoms, but the hallmark symptom that I want you to think about for posterior cerebral artery is cortical blindness. So, arteriovenous malformations, or AVMs as they're called, can be a developmental abnormality where instead of our normal arteriovenous connection, the arteries are connected to the veins by an abnormal thin-walled vessel that's larger than a capillary. A lot of times you don't have any signs and symptoms until they rupture. And when they do rupture, the bleeding can cause dysfunction as a result of lack of blood to the area that the arteries normally supply, and by pressure exerted by the extravascular blood. So usually the rupture of an AVM results in a hemorrhagic stroke.